Okay, so this is going to be an 8-minute talk on arthroscopic releases, fact or fiction. I'm not advocating that every patient needs an arthroscopic release. I'm not saying that this is a must for everyone to do, but this is an option which one has to be aware of. When you look at arthroscopic releases, where have they come from? If you look at the background, open releases have been described for a long time. And we now have data over 15 years. Several centers have been doing it with consistent good results. However, if you go through all the arthroscopic releases material, 2-3 things still stand out. It's little unclear as to the sequence of releases, the quantum of releases, and also, if I may add, what you have to do to the subscapularis. So let's get this out of the way first. 85% of the patients are treated conservatively. So there's no doubt about this. We are talking about this 15% group, which is the failure group. So even the natural history has shown that on an average, depending on which paper you would believe, you've got about 20% outliers. They will keep coming back, they're not happy, and really, they're miserable. So this option is available to those 15 to 20%. Now, look at this paper, JBJS American 1996. We are in 2017. So you've got a good long-term track record. This paper by Wong and his group showed that arthroscopic releases improves the motion reliably with little post-op morbidity. So this was done in patients who had loss of motions and they were refractory to closed manipulation. So all these patients had an MUA, didn't really improve, came back, and hence this was offered. Look at this other paper, Trauma and Sports. They looked at the effectiveness of arthroscopic capsular releases carried out once again for refractory cases that were not responsive for 6 months or more. And what did they say? It's a valuable therapeutic choice with minimal complications, and it effectively decreases pain and improves the range of motion. Now, this is my observation. If you follow the frozen shoulder patients, you will come across 2 groups. One, which I call the non-responders. So they are the good guys. They've followed all the rules. They will go to the physio diligently. They'll keep popping pills which you prescribe. And yet, at the end of 9 months to a year, they're still very stiff and painful. Vis-a-vis, you'll have the surrenderers, which I call. They are fed up. At 7 to 9 months, they too have followed the rules, but now the pain is nagging in nature. It's handicapping and it's interfering with the ADL, or activities of daily living. And they will say, look, doc, I can't tolerate. Let's do something. So when do you consider surgery? So their primary adhesive capsulitis, which you've identified them as, there's no history of major trauma. They all have strong symptoms greater than 6 months. Failure to show progress after rehabbing with a dedicated physio. So if you were to do dedicated shoulder work, I do believe you need a dedicated physio as well, whose competency levels you're well aware of. And if he or she says that, look, we really worked hard, we're not winning, that's when you put forth on the table that this is a viable option. I certainly look at diabetics and post-minor trauma also in the same frame. Now, what are we releasing? This is very important. Basically, when you get in with the scope, the coracohumeral ligament here, which you see, and the rotator interval has been looked upon in great depth. So your rotator interval, according to me, is actually a misnomer. It's not an interval, it's not an empty space. It is actually tissue which is capsular and ligamentous, which contributes a huge amount to your static stability. So you have to be releasing the anterior capsule. Sorry, let me just go back. It's gone. So you have to be releasing the anterior capsule, which is here. You release the posterior capsule. You do a synovectomy, you do a rotator interval release, and then I divide the subscapularis as well, and then you go down and you complete what the manipulation has started in terms of releasing the inferior axillary pouch and part of the capsule. So the rotator interval is released by starting the capsular division anterior and inferior to the biceps tendon. And you continue till the upper edge of the subscapularis. I divide the tendinous portion of subscapularis as well, and I find that it is more predictable and it gives earlier results. Mind you, this is all contracted scar tissue. You really don't know, as Dr. Aditya showed, that the inferior capsule becomes thickened and adherent and contracted. So what your conventional thinking is that the axillary nerve is about a centimeter below the 6 o'clock position here. You just don't know where it's going to be when you're doing an arthroscopy. So I stop my divisions at about 5 o'clock. I do it all in a beach chair position. This is the video of how I do it. It actually takes about an hour or so. This is a compressed version over 6 minutes, but I'll run this forward. So initially, because you've done a manipulation, it's all a bit bloody. You then get in with the arthro wand, and you'll find that there is synovitis at the top. So below the biceps tendon, the superior aspect of the capsule, you'll see these inflammatory fronts, which are really angry looking and inflamed. So the first thing is to partially ablate whatever you can. It's like a arthroscopic synovectomy. You can never really take out all of it, but you try and ablate whatever you can, and you're basically inhibiting the pain pathways. So that's the first step which I do. Once I'm reasonably happy that I've gone across the roof, I then go to the anterior aspect. This is just a degenerate labrum, which you just tidy up. You then go along the anterior aspect of the glenoid, and you divide the anterior capsule there, or you peel it off. Now, if you go in post-MUA, you'll find that there are partial ruptures across the anterior capsule as well. And I don't really go and complete those divisions. What you really want to do is free up the space, a bit like what you would do a subscap release in the front of the glenoid. Essentially, you want to give them more of external rotation. If you give them ER, they gain overhead function. If there's no ER, there's no overhead function. So you keep working from the front, and then I'll just take this a bit forward. Anand, how do I get this forward? Okay, so just take it a bit forward. Yeah. So now you go in the front of this. This is the rotator interval. That's the superior aspect of the subscap. And you keep on dividing. Yeah, go forward again, please. So you keep on dividing till you see the superior aspect of the subscap. Then you start clearing the rotator interval. Now, some surgeons will tell you that I can accurately define the CHL. I can see where the superior glenohumeral ligament is. I can identify the capsule. It is incredibly difficult. If you see these tight shoulders who've come to you after 6 to 8 months, everything is plastered, adherent, and you really, what you are doing is you're dividing everything in the front till you can see the fibers of the deltoid. So you've got to be a bit patient. You go on ablating it. And then, as I said, I divide the upper fibers of subscapularis as well, and I stop where you come across the tendinous portion. Through the same portal, or you can swap, you do a posterior release as well. And then you give a nice wash, and I infiltrate it with bupivacaine in the post-operative period. Few patients. This is a gentleman. You can see he's got a sternal scar, post-CABG, with a stiff shoulder, borderline diabetic, post-release. This is another lady, stiff to start with, not improving post-rehab, post-surgery. That's the range of motion in terms of rotations, and most important, they can cater to their personal hygiene. Another lady, normal-looking X-rays, and that's the outcome when you see them at about 3 months. Before I wind up, this is an important summary slide. Arthroscopy Journal 2016. Itoy, who was we were lucky to have him here in Bombay a month ago at the AKCR meeting. They said that in refractory cases as well, this was the summary pictorial at the Arthroscopy Journal as well. Those patients who are stiff, manipulation under anesthesia, or arthroscopic releases may be indicated. There's several pitfalls in terms of complications, fractures, capsular avulsions, labral tears, cuff tears. So you've got to be careful. And rehab post-surgery is important as well. So my take-home messages are, you carefully select the patient. Where does this start? This surgery starts where Muga stops. It is not a competition. It is not a contest. It's not that one wins over the other. As I look at it, you've ruptured what you could with a manipulation, and what you can't really attack the culprit organs with an MUA, you are topping it up with a surgery. It is certainly more consistent. At 2 weeks, when you see them for suture removal, they're sleeping better, their pain is less, and they're on the upswing in terms of the range of motion. And certainly diabetics will take longer even after surgery. Thank you for your kind hearing.